Greetings, my name is Cinnamon Dixon. I am a pediatric emergency medicine physician and medical officer in the Pediatric Trauma and Critical Illness Branch, or PTCIB, at the Eunice Shriver National Institute of Child Health and Human Development, or NICHD. The PTCIB was established in 2012 with the mission of supporting research and training activities aimed at preventing, treating, and reducing all forms of childhood traumatic injury and critical illness across the care continuum. The PTCIB's priorities center on the prevention and treatment of traumatic injuries, collaborative multidisciplinary research across the continuum, and psychosocial issues related to the care of critically ill and injured children and their families. NICHD's partnership with HRSA on Emergency Medical Services for Children, or EMSC, extends as far back as 2 decades, at which time a multi-agency program announcement was released focusing on improved quality and quantity of EMSC research. Since that time, our partnership and NICHD's work in this field has continued to grow. NICHD currently supports a robust portfolio of EMSC-related activities ranging from cooperative agreements to research grants and training awards. The NICHD and NIH have multiple current funding opportunity announcements available for investigators and trainees to promote research in the emergency setting, as well as research on trauma and injury, violence and firearms, medical simulation, health services related to minority health and health disparities, and disasters. Additionally, NICHD has a current Notice of Special Interest published soliciting research on EMSC. We also welcome investigator-initiated applications in this field. Here at PTCIB, we are currently most excited about supporting work that will address one of the biggest gaps in the field, the equity and quality of care for children within the emergency medical system. It is no news to this audience that disparities in access to and the provision of optimal emergency care for children exists within the United States and globally. And the PTCIB is committed to helping address these care gaps through our investments in research and training. Furthermore, we believe that some of the best solutions to these gaps incorporate research and training, advances across the continuum of care, and the full translational spectrum of science, meaning that EMSC science takes an approach not only from bench to bedside, but from bedside to curbside. Hence, in addition to bench and clinical practice advances, our support of EMSC research focuses on expanding the number and availability of evidence-based diagnostics and interventions via dissemination and implementation science. It encourages research that operationalizes the use of electronic modalities and other advances in care delivery to increase reach of best practices. And it supports multidisciplinary science, which partners with local and regional communities in participatory research and other endeavors to address systemic inequities in risk and care. As a leader in this area of science for our branch at the NICHD, my vision for the future of EMSC in the United States and globally is that all children will have the same access and availability to high quality care in an emergency situation, regardless of their age, race, gender, economic status, geographic location, or underlying disability. To reach this goal, optimal emergency care services for all populations, and especially children, must be embedded into the fabric of the pre-hospital and medical home setting, the emergency departments and hospitals, and beyond. I look forward to continued collaborations with HRSA and other relevant agencies to promote a future of EMSC in which pre-hospital systems and providers are trained and ready to deal with pediatric emergencies. Medical home providers are skilled and regularly practicing for emergencies in the clinic. Emergency medical providers provide safe and evidence-based practices for the many conditions they encounter every day. Emergency departments have access to pediatric specialists, whether in person or remotely, to manage severely ill or injured children. And that EMSC programs partner with schools, communities, medical home systems, and mental health organizations to increase capability and capacity of these groups to respond to pediatric emergencies within their day-to-day scope, and also to build systems and infrastructure which can be leveraged in the context of a public health emergency. I would encourage any EMSC researcher or grantee to keep checking the NICHD website for updates on current and future funding opportunities, as well as it can be helpful to review the NIH reporter to get a sense of our current investments and to discern where there may be opportunities for collaboration. And finally, don't hesitate to reach out to myself or any of my colleagues to discuss your area of science and learn more about how we can potentially support you. And my final message to all of the current and future EMSC grantees working to improve emergency care for children is thank you. Being a provider in the field of EMSC is both a daily challenge and a reflective privilege. Caring for a child and their family at the most vulnerable moment of their life is a great honor. However, reaching beyond the bedside to improve care and decrease inequities for all children who may enter the emergency medical system now and into the future, that is the most noble of endeavors. And we at PTCIB and the NICHD are grateful for all that you do. Thanks.